Okay, thanks, Stu. Hopefully folks can hear me okay. So I've got a number of areas to go into to update you on, and I guess what I'll do is that as I go through each area, I'll do a pause at the end, and then if anybody wants to ask any questions in the chat or on the call itself, then please do. Okay, so the first one is normally I do these jointly with James Hopkinson, our medical director, GP. James can't make it, unfortunately, today, so I'm going to cover some of his ground to start with. But as I say, if there's anything as we go through that you want to talk more about, we have got the hour, so please do stop me and we'll have a chat about it. So, going to James's handover then. So I've got some bits to update you on. So the first one that he wanted to kind of let you know about, make sure that you're still aware of, is this affecting many practices, but the NUH 5 Asks project. So this was the idea. If you're not sure, then I'll talk about it. If you do, then it would be good to get your feedback. But this was the idea of practices being able to email NUH in a different way to eHealthscope on a set of different asks, some very clear asks. So it's not a general kind of catch-all, although it could really turn into that. But the idea was that it's a clear areas of contract that we've now talked about for years and we found very frustrating. But NUH have now put an email address in to tackle the exact asks. So just to clarify, and again, for anybody who doesn't know this, this will be the first time. If you do, bear with me, and we'll talk about how this could work. So this is on a number of areas. So this is on communication. This is about NUH communicating clearly and concisely with yourselves and making it clear to patients as well what actions are going on. So this is the bit around NUH talking to patients and to the practices around any patient care and being prompt with those communications and clear. Referrals. So this is something we've talked about, goodness knows how many times. So this is around internal referrals. This is around if you refer somebody into the hospital or somebody finds themselves into the hospital system and they need an onward referral within the hospital for a related issue, or for the original issue, then that should be handled by the hospital. That should be done by the hospital. That's not your work to do. It's very awkward when the patient comes back to you and it feels like your work, but strictly speaking, it's not your work to do. So when you get any instances like that, that's the kind of thing that you need to be pushing back on and emailing this group. We can put the email back into the chat as well to make sure that that's clear to you. But it's a feedback email. It's nuhnt.gp.feedback@nhs.net. But onward referrals is a really important one. That isn't your clerical job, and let's face it, for the patients, it's easier, isn't it? So if the hospital can send that on within the hospital, that's better for everybody. That does apply to ED as well. Now we know that a number of people have fed back to us that ED doesn't seem to be operating in the same way. Well, they should be. They're not different. They're still part of the hospital contract. So we'd expect ED to be doing onward referrals to other parts of the hospital if they think that that's necessary and related to why the patient came to the hospital. Results. So they should be following up their own results. Tests that the NUH are undertaking tests. They should be following up their own results and informing the patient and completing any actions as required. That is up to them to do. You're not their secretary. You're not there to do their roles. They should be following up their own investigations. Fit notes, we know about this one. The common one I think we find with fit notes is obviously the one where somebody either doesn't get a fit note and there's some kind of reason why that hadn't happened, or they do get one, but it's for a very short period of time. And it's obvious from the outset that it should be for a longer time. So again, that's what we're talking to them about at the weekly interface meetings, at various sessions that we have with the execs at NUH. Fit notes should be done for the time that is estimated that it needs to be there. So somebody breaks their leg, it should be fairly obvious how long they might be out of work, depending on what work they do. That's up to them to do. It's not up to them to give a holding kind of a few days until they can get into the GP. It's up to the hospital to give a fit note that should cover the duration that they need. And prescriptions. So they should be providing prescriptions to patients for any new or altered medications. Excuse me. That should be done there. And an excuse that the pharmacy's busy or this or that, don't really cut it. It's not great when the patient then has to go back to you. You haven't seen them for the reason that they've gone to the hospital, and then you're asked to provide a prescription. That should be done by them. So they're the five asks. So these are things we have asked for years. We've used BMA template letters. We've had various meetings. We've had all the eHealthscope meetings. Um, this hasn't changed, but what has changed is that NUH have adopted a policy around it now. They've kind of met us halfway and they've said, okay, you're right that this needs to be done. And so they've worked with us and with other colleagues on the interface to provide a way of reporting this. And what we should get is we should get reports back. So we should get an answer when you're emailing this. The turnaround we were told would be within 2 weeks. And we've heard that there's about 70 or so that have gone in already. So that's quite a lot of work. I suspect that's the tip of the iceberg. James feels the same. So what this might do is really show the scale of how much the hospitals are not following their own contracts. That's useful for us in one way, but it's going to be frustrating if it clogs up again. But there is a renewed effort to do this. So anybody who's reporting, please let us know how you're getting on. If you get a good response, let us know. We'd like to feed that back. But we'd also like to spot where there might be areas of the hospitals doing better than the others, because it's such a big place. We might find that some departments are much better at this and others don't really get it. So we need to know what's going on, and we will continue to have those interface meetings where we pick up on any themes. So let us know how that's going. That's the Five Asks program. And obviously what we're doing with both Doncaster and Bassetlaw Hospital and Sherwood Forest is trying to take some of the learning that we're getting from NUH, who, okay, there is a lot of work that still moves over, but they are working with us. They are trying to change things. That much we do know. But you'll know how successful that is by what you're seeing in your practice. So that's about that. The leadership in the NUH are pushing back and supporting this because they know that this is supposed to be done by hospitals. They should be doing their own work. But we need to know how it's going. So that's the NUH 5 Asks project. Please do let us know how that goes, successes or otherwise. Neurology, this is linked. So this is another part of James's update. And as I say, at the end of this update, I will pause and we can discuss or ask questions. So Lucy and James met, I think it was last week, with neurology and discussed the concerns mainly about the referrals and mainly about this kind of sifting process that they have there in neurology. So this still is happening. We're still seeing people who we believe should not be getting turned down for a referral, that we should be getting seen in the hospital. We had reassurances that if it's very clear in your referral letter that you're concerned about your patient, you're worried about them, and you really want them seen by neurology, that they would see them. That's what we were told. That's what we need to keep pushing. Because it's that difference between, well, actually, does the referrer really just want some advice to help them with their management of that patient, or do they really want a referral? Do they really want the patient to be seen? So as clear as we can be on the referrals is the better, and we will keep pushing if we're seeing examples where that isn't working. But there is two-way on this one. So we're offering, and they're offering in NUH, they're offering to get GP working with them to kind of look at some of the referrals that come in and understand the processes that NUH take when they get any neuro referrals. So what we're hoping is that by doing that we get a GP who can look at the referrals, working with neurology department, and maybe kind of do a bit of quality work on it. That's what we really need to see. We need to see the quality of what's going in, the reasons why decisions are being made at neurology, and we need to interrogate that. Lucy, you were at that meeting, and without putting you on the spot, because James has covered it, but is there anything else you wanted to say at all around that?
No, it's just the
Oh, you've just gone on mute, Lucy.
you'd think after 4 years it'd be better than that. No, you've covered it, Michael. It was just about the offer. So Dr. Caroline White, who's one of our LMC committee members and as part of the interface work for the strategy, is going to be spending some time with the neurology consultants in early new year, looking at the vetting process and sort of sharing reflections back with the committee about how that's going.
Great, thanks, Lucy. So yeah, so we're getting more of our elected committee GPs who you elected earlier in the year, getting involved in various pieces of work. and so that's good that we've got that. A few other bits from James, so I'll carry on with the list. So we've worked the ice. We've been working on ice in terms of the ferritin pathway, and it's been simplified, says James. So it should now be a single page. And currently, there's work going on with urine requests, which are quite unwieldy, and to simplify that. So again, you should see some progress in terms of ice on that one. There's ongoing work with iRefer. So this is one that James has been quite passionate about, really, and not really been happy with some of what he picked up when he came into post. So he's had a meeting with the software authors and fed back how poor the system is, and it's not really supportive. It's really a filter and could be a lot more than that. Apparently, he said there should be an other box that GPs can choose if the pre-filled boxes don't fit. So please use it. And again, let us know if there's any problems with that when you're using iRefer, so that if it isn't working in the way intended, that we can still make some tweaks to it. But that's his workaround at the moment. There should be another box that you're able to choose if the pre-filled box don't fit. One other one before I talk about the England LMC conference. One other one was ASS1 forms. I don't know who makes these up. Somebody's having a joke here, aren't they? So the AS1 forms, the ASS1 forms. Here we go. So James is telling us on this one that this is obviously around the prescribing and working in the community. So they should be in place in the new year so that NUH could complete for district nurses without having to come back to GPs. So I think James is going to update on that when it's live. As soon as possible. And I know that TeamNet carried some details as well about the uses of these forms and various prescribing forms. So more on that as it comes through. But James did want to let you know that this will be coming in the new year and that there will be an update when they're live. He also mentioned the England LMC conference, so I'll go on to that and then I'll just take a little pause. So James was one of our delegation. We have 5 GPs who go to each LMC conference as representatives of the profession in Nottinghamshire. So there's an England one in November. There's a 2-day UK one in May. So this was particularly around, the theme really was around a lot of it about the financial situation, about the contract, about the worries over national insurance and minimum wage, etc. But also a lot around regulation as well, and looking at regulation of PAs, etc. So there was quite a wide variety. And if you want to look at those, again, we can make sure that's in the chat. But Stu's uploaded that onto the LMC website. So if you want to see what happened at the England LMC conference and what outcomes were there, you can read the full report, which is on the website. It only came to us last week. It normally comes a few weeks afterwards. The main outcome, I guess, was around collective action. So there was a resolve really, which was that the current collective action that's going on is being felt in Westminster. It is being felt by the Secretary of State and the Department of Health. They are concerned about it. But there is also a mood among many of the GPs that it doesn't go far enough, especially since the autumn statement when we heard about the changes to minimum wage and national insurance. Now, the Secretary of State has written to the profession to say that there will be a fix, that they are recognising that this is a pressure. And we've talked to local MPs as well. We had one with Steve Yem from Mansfield last week to flag this up, as well as writing to all our Nottinghamshire MPs to try and get more support for the profession on this one. So there will be a special conference next year, and within the first few months of next year, there will be a special conference, which is a one-off one where LMCs will come together nationally to talk about collective action and the idea of what options exist in terms of escalating further than we are today. That would be interesting to get your thoughts on. It would be really helpful to know from practices what you would be willing to do in the name of strengthening the arm of the BMA when they're representing you in negotiations. What are you willing to do? Do you feel that what we've got out there is enough? If you think there's more that should happen, please let us know, because we need to represent your views when we go to these conferences. Now, I have spoken to some local GPs. One GP in particular said that he didn't think the current collective action was that helpful, but he would be willing to close the doors for a day if it meant it got the attention of the government. So, that's one what's really interesting. That would probably come up on the collective action special conference as an idea. What we as an LMC always try really hard not to do, and we shouldn't do, is that we shouldn't tell you to breach your contract. Obviously, closing your doors for a day is breaching your contract. Now, if everybody breaches the contract on the same day and closes their doors, or 90% do, that's the problem for the ICB. If 9 practices close them on one day, that's the problem for the 9 practices. So this is one of those things where we know that strength in numbers really does count. There are some views out there that we don't want to affect patient safety, but that we really want to make sure that people know the strength of feeling in general practice, and that the profession really does need a big help here in the contract. So we will talk about that in the coming months, especially between now and kind of the end of January, around what we're willing to do and what would be viable to do under collective action. That's not to say we should stop what's going on already. So we've heard some good stories of what's happening out there. We've heard a lot of good things about the numbers on the 25 contacts, and some practices are changing the numbers to suit them. But just that notion that you're not inexhaustible, that you're not infinite, that you do have to stop, that you do have to have breaks, that you do need to treat your team better. And if that means more people wait to get seen, then that might be a byproduct of it. That's different for us in general practice, but everyone else in the system seems to be okay with that. So we need to look after ourselves. That, I think, is the area that we've seen the most take up on. So what we want to do is hear more from you about that. Collective action continues. That's a practice level decision if you want to take it. And if you want us to come and help you to talk about what you could do and how to do it, then we'll do that. Um, as a result of discussing this nationally with other LMCs, we're also talking on Thursday in a group about learning from each other. So what's happening in different areas around England with collective action, and what are LMCs doing that's supporting their practices, and how's that working? So there's going to be a bit of an exchange on Thursday, facilitated and helped by us because we run the network nationally. But actually, it's a chance for us to hear what goes down well in different areas, because actually some areas have really high levels of collective action that are being taken up, probably very militant in the way that they've approached this, and perhaps we're doing some of this already and have really built on it. So it carries on. We'll find out more on Thursday what works, what doesn't work in different areas. We'll bring back some learning for you in your practices. And I guess the message is that we don't stop. We've got this situation where over the next 3 months, there's going to be negotiations over what the contract looks like for general practice in 2025, 26. So this can't stop. This has to be that BMA have got something to be able to hold the government to account with and to get some kind of leverage. The positive at the moment is that the new government does seem to want to talk. It does seem to want to work with the BMA. And over the last two years or so of the Conservative government, it got to the point where it was contract imposition. There were no real negotiations. It was imposed contracts. So there is a light there. Potentially, there is a lot of work being done, and a lot of GPs and through the LMCs are lobbying their MPs to make a noise at national level about this. Because even before, this feels a little bit like a distraction, but even before the autumn statement, general practice was going backwards. We were running backwards, trying to keep up. And then we had the autumn statement. So even if we get a reasonable fix on the autumn statement, we were still well behind, as we know for our sustainability survey that we did earlier in the year. So I'm just going to stop at that point. And if there's any questions either through the chat or comments, or anyone wants to come in and put their hand up, then please do. So this was James's update, and I've tagged on a little bit more about the conference there before I move on to the strategy and the STS, because they're the next 2 areas I'm going to go for.
Great stuff. Thank you, Michael. In the chat, we've got a couple of questions. One's from Dr. Andy Summers. Michael, is it worthwhile thinking how we manage rejected referrals? I wonder if the NUH email process for the 5 asks, hopefully to be replicated at SFHT, could end up being a route to manage rejected referrals as well. Just keen to avoid the back and forth merry-go-round.
Yeah, I mean, I think whichever way, Andy, we need to know about the rejected referrals. Who are they from? What are the reasons being given? We do know that some practices have asked, when they've had a rejected referral, particularly if it's not been clear where the decision has been made, that they've asked the hospital to give the details of who made that clinical decision. We want to make sure it's a clinical decision and it's not an admin decision, because it's not the right template form. It's not been done in the right way. It's not ticked the right boxes. So I think some of this depends on what the reasons for the rejected referrals are. Clearly, the internal referrals are part of the 5R, so that should be handled anyway. But I think if you can let us know, as well as if you push back to the hospital directly, the email address was actually launched with the idea that that would be a feedback mechanism for NUH. So personally, I would say go for it. If you want to use that email address for the rejected referrals, please do it. Let us know what's going on so that we can chase it up. I know they're doing the 5R through this, but the original intent was to have an email feedback address for NUH. So yeah, that seems legitimate. But let us know so that when we're talking in the interface meetings about any of this, that we've got some themes. Because what we can't really tell right now, is it certain departments that are doing this more? Is this around admin? Is this more around clinical? And we have had conversations with NUH where they ask for the GMC numbers have given from practices. That's caused some problems. Some of the people in the hospitals feel quite threatened because they feel they're going to be taken to GMC. Obviously, what we're saying is that we want accountability for decisions that are made. So if a GP refers someone in good faith and somebody rejects that referral, well, clinically, who made that decision? That's the bit we're going to push on. So please use the email address. Yes, Andy, I agree. Do that. But please keep us up to date as well so that we know what the picture is.
Great stuff. Thank you, Michael. Question in the chat as well from Dr. Palm Panazar at 12:13, if you're following the chat. Hi, Michael. Has the issue of referrals to neurology converted to advice been considered in terms of the contractual obligations of NUH under the secondary care contract? Can a provider refuse to accept a referral contractually?
So I think that's an interesting question. So I think their referral process is the bit where they're saying that they're making decisions on refusal. So what they can refuse referrals, but they have to give you a clinical reason for it. But they're going through this sifting process. So by doing that, we've really resisted anything that looks like advice and guidance instead of referral management. So we've really resisted that. But if they make a decision on not seeing somebody, then, of course, they can refuse to see someone if they feel that, that there's a clinical reason for it. The bit that we're trying to fight with them on is that ordinarily when a GP asks somebody to be seen, they genuinely mean to be seen. They're not asking for advice. They would ask for A&G if they wanted that. So I think that's the bit we're pushing with them. It's over the processes. As Lucy said earlier, we've got Caroline who's going to sit and look through these and do some quality checks on them. So, are there any that are being refused to be seen in the referral system because it's the system that's stopping? Or are they all having a clinical eye on it that's saying, actually, whichever way that comes to us, we would not see that person anyway, and we're making a clinical decision. So this is the bit we need to see. What's failing here? Is it the process? Is it the quality of the referrals? And this will be a mix. The answer will be a mix of all of these, I would imagine. Is it around the resources for secondary care? And this is a really tricky one that we know is going to come up, but I feel like this is an ICB discussion. And that's the bit of that NUH, neurology as an example, will have a finite resource. They will have a finite resource of what they can deal with, and a big backlog of people is what we're going to get if there's no other way of dealing with referrals coming in. So if they see everybody and they contractually have to see everybody that gets referred to them, then we're going to get a much more growing list. Is that our problem in general practice? Well, that's debatable, isn't it? Contractually, no. But if it's you who are maintaining that patient who is 18 months down the line on there, well, maybe you'd like it if they thought of another way of trying to deal with that patient. So I think it's incredibly difficult. But I think that what is defendable is when they make a decision on somebody and they've seen them, great, fine. You've made that decision, you've seen the patient. If they don't see the patient and you're still concerned, I think you've just got to stress that. The bit we're trying to chop out is the bit where it gets back to you to then say, I'm still worried. We're trying to chop that bit out. So just make it really clear on your referrals that when we're sending this referral to you, we don't want advice. We don't want you to send this back to us and say we're not going to see them. And if you do it, tell us who's made that decision and tell us what the ongoing plan should be. So, I don't think they're trying to, well, I don't think they're trying to avoid work. I think they've just got a system where their resource is not coping, just as general practice doesn't cope at the moment. So they have to introduce something that allows people to be, I guess, processed, if you like. Doesn't feel like a very patient-friendly comment, does it, to say you're being processed? But they have to have a way of not seeing absolutely everybody who comes in if they don't medically need to be seen. But if you think they need a referral, then there's a mismatch, isn't there? So
Great.
again, Lucy, I don't know that. I think you covered a little bit about their resource, and in a way, it's an ICS problem, not our problem. But I think that was part of the conversation about having a system that allowed us to still have clinical decision making over neurology patients.
Yeah, that's correct.
Okay.
Great stuff. Thank you, Michael. Dr. Parmpan has also come back in the chat in terms of what I would say is that a referral to a secondary care specialist is reasonable to triage to various destinations regarding providers, but to return to a sender is a patient risk. GPs are highly skilled, but not neurologists. Triage is only as good as the information provided, and diagnostics are heavily history and specialist examination.
Can't argue with that, Palm. Can't argue with that.
Just to say as well, Michael, we obviously have direct links in with neurology, so if you can continue to forward any examples directly to us, as well as reporting on the 5 asks or eHealthscope, whichever your preferred mechanism is, we can then take them. It was really helpful when James and I met with Dilsa last week or the week before, because we had case studies that we could sort of talk through and help see both sides of the argument, really. So please do share them with us, because we meet quarterly, and that's a direct way that we can raise these issues for you.
Great, thank you, Lucy. Going back to the chat and continuing the theme of the 5 asks. So Dr. Calibert has put in there, Michael, can you just reassure practices that safe working is intended to stay even when collective action ends?
So I guess the answer to all practices here is that it's not our collective action and it's not our safe working. We're pushing it, we're encouraging it. What you do in your practice is up to you. If you want to do safe working for the next 20 years, do it. I'd say you should. I'd say that safe working is in a way, safe working is what you should do as business as usual. It's not a separate process or program, but it's been on the BMA list. I think they've been doing this, pushing safe working for about 4 or 5 years now. It's only now that it's almost been, dare I say it, weaponized for collective action. But safe working is what we should all be doing. And any of those things on that list, you can turn off and on at any point. So the other bit that strikes me is this bit around on non-commissioned work that you're doing. So it's a little bit like safe working, because it's about protecting your resource. So if you're doing any work that isn't commissioned, inclisiran's a good one. We have no end of chats about this and discussions about this with the ICS. If you're doing inclisiran and you're not getting paid for it, and it's not under a LES, as it's not in Nottinghamshire and it's not in most places, if you're doing it and you don't want to do it, then give 3 months notice to the ICB that you're not going to do it. So you can do that at any point. I think the difficulty is sometimes understanding from a practice point what's contractual and what isn't. But all of these things on collective action you can do or you can not do for the next 5 years, 10 years, 2 months, 1 month. But you're right, really, Khalid, in the sense that the biggest, most obvious one to carry on doing, irrespective of collective action, is the safe working. Limit your contacts, change how you deal with capacity against demand, and get yourselves to the point where what you can control is controllable. But it takes hard decisions, because initially it feels like you're reducing your capacity.
Great, thank you, Michael. Dr. Jen Moss-Langford has put in the chat, is the LMC asking or encouraging practice to try to use the 5 asks letters when bouncing back inappropriate responses to NUH instead of using their own letters, which would mean that the med directors at NUH were more aware of where the problems are in their organisation?
Yeah, I mean, I think there's a bit of meeting them halfway, isn't there? So I think there's an element of they've heard all of our concerns and they wanted to try and contain it, but not contain it. I guess what they're trying to do is to get them in one place where they take responsibility for acting on them. So that is why they're doing it under this scheme called 5 asks. Personally, I didn't like it. I thought that this was all in your contract. Why are you doing it as a scheme to help general practice? You should be doing it anyway. But if this is how they want to enact it, and it becomes a phrase they can talk about within the hospital, fantastic, great. Go and tell everyone about your 5 asks. Should be doing it anyway. But by all means do that. So yes, please use the 5 asks. Use that email address. It's quite short. There's a standard operating procedure that shows the process. It's been uploaded to TeamNet, and there's some forms on there. There's bits of information you can find out. But if it all goes through that one route, it does give us a direct way of interrogating it that we can do. And that's probably the difference between that and eHealthscope in a way. Because over time, eHealthscope has become about themes, about getting reports periodically about what's going on. Actually, we really want a direct line with the hospitals about stuff that's getting sent to them where we think it shouldn't. So please use the 5 asks. Jen, you're involved in the interface work. So if there's anything you want to add to this at all, then please come in and we'll have a different voice to mine. You're very welcome to. I've left that open for Jen. Okay, Jen.
Hello, can you hear me? Is my microphone working? Yeah. No, thank you very much. I think that it's really good, the progress that's been made, and I think that the 5 asks is how they've phrased this for their staff. It's actually and so their staff can realise rather than really to externally face, because we know that this is all meant to be in their contracts, but actually a lot of their staff didn't know about what should be in their contracts. So it's a really good move from the senior management in there to actually say, actually, these things are in your contract. It is actually your responsibility. So these are the, where we're starting and focusing. So we ask that you always do this, and it's not asking us in GPs, it's asking those consultants. So I think that that's the powerful thing, that this is the senior management in NUH are asking all of their team to do these things, and it's our job to highlight when that's not happening so that they can then work on where things need focus. And if they look at it with different specialties, they've had 70 letters through, as you said earlier, but to see how many are ophthalmology, how many are gastro, how many are there, so they know, does someone need to go and have a little word with whatever department, because this is looking like they're particularly bad at doing sick notes or something. So I think it's a really useful tool, and it will be really good to be able to see the evaluation. And as an LMC, we've offered our support in helping them evaluate some of those as well, where they have problems. And I know that Sherwood Forest are working on the idea of doing something along the same lines, but this would be in the new year. They obviously have to get all the ducks in a row to make it a safe process. And there was a lot of thought went into how to make sure that these letters that are going in produce a safer response. So instead of lots of different letters going to lots of different places within NUH, they're saying, please, can you try and funnel them through here? And then we'll make sure that they've been followed up within a certain amount of time. So there's a chap called John Peach, and he'll actually go and chase, you had this letter sent on to you, but we haven't received a response yet. Can you hurry up? So that's the chasing from their specialist. We've never had anything like that before. We've never had a hospital offering to do, wanting to do that there. So I think it's a really good step in the right direction, and we just need to be there. And and I think the putting as much through that route will be really helpful. I don't think this will be extra things that we're reporting. It's just about channeling all of the things that we're already doing into that one direction, because we should be always pushing back against these things.
Great stuff. Thank you, Jen. Debbie Swain's put in the chat, if it's not contractual, do we have to give notice?
Technically, no. So technically you don't. If it's not in your contract, it's not in your contract. Who could hold you responsible for stuff you're doing that's not in your contract? Nobody can. So no, the technical answer is no, you don't have to give notice. We recommend you give 3 months notice. The BMA recommends you give 3 months notice, and that's only on the side of patient care. That's because so many GPs do so much free work that's not contracted that they'll never stop doing it because they really worry about their patients. They care about the patients. Let's be honest, people really take advantage of that. I don't mean our patients, but I mean some of the decision makers and management who allow you to do so much uncommissioned work and not paid for. They take advantage of your goodwill because you'll do it. So the 3 months is a recommendation. what we'd really like you to do, if you see work you shouldn't be doing, is just to serve notice to the ICB that you're going to stop doing it. So, you know, that's the point. So rather than do work that you realize at some point that isn't contracted, there's no les for it, and you're not signed up to it, we're just saying, just let the ICB know. You know, we think the best bet is to give them 3 months notice. It gives your patients time to hopefully get a service from somewhere that's commissioned correctly to do it, even if it's you. But if we don't push back, and if we don't serve notice on work that's not commissioned, there's no incentive for anyone to set up a service for it. There's no incentive to the ICB to set up a les for something. Why would they? They're getting loads of free work. If I was in the ICB, I'd do the same. So, you know, that's the point of the 3 months. You could just stop doing it, but, you know, most people are worried about the impact on their patients, about not getting what they want. So that's why we're saying, you know, 3 months is recommended, and that's the BMA's line. But if you stop doing it tomorrow, nobody can make you do it.
Great stuff. Thank you, Michael. Just conscious of time. Okay, comment from Andy Summers in the chat. Just for information from an SFHT perspective, we, the LMC, are due to meet with SFHT again this Thursday and contribute to their ongoing similar interface work. Please feel free to email andy@asummers.nhs.net about anything related to this. That's information for practices out there today. Okay. Okay, over to you, Michael.
Yeah, I mean, Jen's put something in the chat there as well. I've just noticed. Do we want practices to let us know if they're serving notice on any services? Copy us in. If you write to the ICB, copy us in, or any of your commissioners, copy us in. It'd be useful to know what response you get, and equally, it allows us to understand what else is going on under collective action. But again, this isn't just for collective action. Just like the safe working, if you're doing work that's not contracted, irrespective of collective action, just serve notice on it. Let the ICB think about how they're going to commission it responsibly, and let us know. Okay, I'm going to just talk about, link to that really, ESDS, and then I'm going to touch upon our strategy and again open it up to any feedback. So the ESDS letter, all I want to do is just a verbal update based on the letter that we sent out the other week. Now, what we did, just to track back really, so what we did over ESDS, if you think about this, has taken best part of a year as an approach. And we always said that what we would do if we had enough practices who didn't want to carry on doing the ESDS is that we would coordinate. Now it's you're the contract holder, so it's you who have the final say, but we would coordinate action to hopefully get to the ICB into the place where they might uplift the ESDS rates. And make it more easy to do, actually, the dressings and some of the issues around spirometry, etc. So we did build some groups to work with the ICB. So, the ICB did meet us on this one. They did meet us halfway, and they had a delegation of people from practices in the LMC to work with them on this one, to review their enhanced services, and particularly ESDS. We did do a poll a few months ago, and a number of practices said they wouldn't be willing to stop doing the SDS because it's income that, albeit it might be questionable how profitable it is, but practices really rely on that money, and they would really miss it if that money wasn't there. So if they sent notice on it, then they would lose that money, and actually that could be a viability issue, or it could be an issue around having to make redundancies, and practices don't want to do that. So that's fair enough. That made it quite difficult, though, especially when it's a basket of services. When it's individual services, as we've seen in Derbyshire and Leicestershire, or when it's 2 or 3 services bundled together, that's quite a lot easier to negotiate, because we can really just strip them out and say, okay, that's what we need for that, and we can move away from that. But when it's so many services rolled into one payment, it's all or nothing. It's a block. So we've heard your views. We did go out to practices to ask what you wanted from ESDS, and the majority of people who came back did say that we want this broken down. We want this disaggregated. We want individual services that we can have commissioned at the right price, and we can see then what we're doing for what money. Sounds completely sensible. Seems like the thing we should be doing. That isn't going to happen quickly. So that's not going to happen for April by the looks of things. And part of the reason is that the ICB haven't done their work on this one. They don't have activity levels for all of the different services within ESDS so that they can quickly predict how much it will cost them to commission it, which sounds a bit bonkers, but that's the truth. So where we're at the moment is that the ball is very much now in the ICB court. So we should be hearing from them within the next 4 or 5 weeks, I would hope. We've obviously got Christmas break in the way as well. But they should be showing their hand as to what they're going to commission now for next year. Is it going to be changed? Are there going to be changes to the rates or to the service spec for ESDS? These are the things we've asked. Could they look at something more radical where they just get a sum of money out to practices on a high trust, low bureaucracy basis? That's probably what we prefer. And when are we going to know? So these conversations are ongoing, and we need to know very early in the new year about what we're doing and what this means for you. There is an existential threat we've talked about with this, in that it has been said in meetings with commissioners that if practices opt out on a mass basis from ESDS, that there are others who would pick it up and do the service themselves. So that's difficult for us. We don't want that. We don't want it easy for the commissioners to go elsewhere. We want it to be very much here in Nottinghamshire where it gets done. We won't know unless they try to do it, whether they can actually go out and provide it. Who knows? But at the moment, they've got an offer on the table that if practices opt out, there's somebody else that would be willing to pick it up. It'd probably be worse for patients, probably be a lot worse for patients if it's not a commission service directly from you in your practices. So we don't want to do that. So we're going to find out soon, hopefully, as to what the outcome is. But we did work on the data. We did work on getting the accountants to cost this up for you. And at the end of the day, you as contractors, you're in a contract with the NHS. You're in the contract with the ICB over ESDS, and you need to make your own decisions on it. What we're trying to do is get the leverage to get them to uplift the right parts and to do the proper work. But this could be, this could be over a year, 2 years, 3 years to get to the point where it looks like it should. Because if we're going to get it individually broken down, if that's what the aim is ultimately, that's going to take at least until April 26. So we have to think in our practices and keep talking between the LMC and practices about what you want, about what you're willing to do. But we need to see the offer for April onwards, and we've not seen that yet. Is there anything else, Stu, on that one before I go on to the strategy?
Well, this Debbie's mentioned that it looks like Newark won't be continuing with ESDS. Dr. Calibert, is
no, I didn't mean that. I meant if they did the SWOT analysis, I think they struggled to provide our level of, the capacity and everything in Newark, with premises, workforce, everything. So, I don't think that's necessarily a threat to us, really. I don't think.
Well, thanks for clarifying that, Debbie. Dr. Calibert's put, if individually funded, which is what it should be, just dressing would bust the ESDS budget.
So that's a good reason not to do it then, isn't it? So this is the bit, isn't it? How far are we going to go subsidising the commissioners who should be paying properly for this work? It's held over as the threat all the time that we need this income, but you'll do work for your own costs. So we're trying to correct this. We don't want this to be the way it goes forward. We don't think this is safe. We don't think this is okay. But because it's such a big block and commissioned the way it is, it's going to take time to untangle, to detangle. But we need to see what we need to see what they're planning, and get them to show their hand. And there are people within the ICB who are fans of a radical change in the way this is commissioned. So I think there's going to be some really interesting conversations going on there at the moment.
Great stuff. Debbie, you got your hand up. Do you want to come in on
It was just a question really to other surgeries if they're experiencing it as well. But we've been looking at our dressings costs, and we were kind of thinking, God, why are we spending so much money on dressings? And because we do issue scripts, and what we're finding is the pharmacists aren't giving the scripts quick enough because they've not got the stock in. They can't. So I've been talking to Rebecca Dickinson about it, and she said pharmacists with dressings don't order them all the time, so the patients have to wait. So we should only be using our stock for initial assessment dressings, but we're not. We're continuing to use our stock for 2 or 3 weeks until the pharmacist gets that prescription in. And then sometimes by the time they have got the prescription, the program has changed. So then we're back to square one. So we're using huge amounts of dressings because quite a lot of ours are kind of ulcers with drug addicts and things like that, so they don't always bring them to appointments either, which don't help. So I just wondered if anybody else has seen delays with a pharmacist and getting the prescriptions, and that's costing them more, as because we're just using our own stock. We're spending about 10 grand.
Okay, thank you, Debbie. Paula, you have your hand up. Do you want to come in on that? You're on mute at the moment. Hi, Paula, you're on mute.
Sorry about that.
Sorry.
Yeah, we're experiencing the same as Debbie, delays with the pharmacy, but also the dressings are becoming a lot more complex as well. So, we're doing a lot more dressings, and some of those are very that should really be undertaken at the hospitals. They're discharging them into primary care, so we're seeing them for a lot longer, more daily dressings as well. So yeah, we're experiencing the same. We really need something to happen with the dressings.
Yeah.
We're also seeing that the ulcer clinic as well, because we have some erratic patients, they're refusing to take the referral now. They're saying because one of our patients, for example, DNA's quite a lot because he's homeless and all that kind of stuff. They've just said, no, we won't accept your referral, even though they need compression. So we're actually trying to get the outreach team to him to see whether they can get him to his appointments, but that's kind of fallen back on us. But it's, it's not really appropriate because we're dressing something that we can't dress properly. So I'm in that battle at the moment. But
yeah, we're increasing dressings all the time just to try and keep up with the demand. It's really not
but it's
great.
taken away our appointments from our coif work now, because it's literally just dressing, and they're just turning up on spec and fitting them in 3 times a week and complex. So it is having an impact.
If you had the choice, and we know that money is always going to be thrown up as the excuse not to do the right things, but if you had a choice and ESS did stay for next year in the way it is, but dressings could be commissioned separate from the block, would that be helpful?
Yeah, I think it would. I think it would be, because we could assess how many we're doing.
Yeah.
The thing is with dressings, you pick up, you safeguard and safety net so many patients. I mean, we had one come from abroad who'd had an operation and she got plastic in her wound, and we're still waiting for surgical to pick her up. We've referred her in. We sent her to A&E. They just sent her back out to us. We're dressing it, but she's got a right mess. And it's all this little trip down to the doctor because the patient's ill, or it's all this kind of stuff, that all that value added that they would never get anywhere else, and people had just slipped through the net. All that safeguarding that goes on.
Yeah, it's massive. Yeah, okay, so we'll keep pushing for that. We'll keep pushing for wound dressings to be recognised separately, because it's just getting lost in the box and it's not happening for you, as it is causing a lot of problems. The other bit you mentioned there was around pharmacies. So please give us any feedback around pharmacies, because we're meeting the LPC in the new year, and the LPC are our version for pharmacy, the community pharmacy they're called now under a rebranding, but also only over anything around Pharmacy First, where that might be causing you problems on any issues that you're getting with patients coming back. Anything around pharmacy, please let us know, because we're going to meet them in the new year, and then we'll come back to you and reply to anything that you raise to us as well.
Jen, you got your hand up. Do you want to come in on that?
Yeah, I just wanted to come in about the pharmacy state. I think we should be definitely doing what Michael says and come back with all the problems, because there's a world of issues. One thing that pharmacy has raised into the system is a problem with drug availability, and when the prescription is, it's due on Friday, we issue it on Friday, and the patient wants the meds on Friday, it can be very hard for pharmacists to get hold of them when there is no availability. So there's a document that's been done by the APC, kind of asking basically for leeway in that week's worth where a patient can physically request a prescription on the NHS app, to be able to issue those early. I mean, obviously, I've raised there are safety concerns because some patients want basic. If they do that every month, then they're ending up with 3-week prescriptions rather than 4 weeks. But there may be something sensible about making sure that you're not creating a problem that will come back to you because this drug isn't available, and the patient then goes and says, well, can you give me a different one? Which is what we want to avoid, is making sure that we can get that prescription potentially a little bit earlier to the pharmacist to allow them, because they have to order, they don't have as much stock as they used to, and frankly the drug shortages are the biggest headache for us and them. We know with a wide wide range of things that are coming in problems. So it's just something to consider, is bringing some of those prescriptions on non-concerning abusing patients, they're the normal patients, bringing them a couple of days forward. And I know that's something we quite routinely do at Christmas, anyway, for quite a lot of patients because of the bank holidays. So, but it might be worth thinking about doing as a one-off, bring them 2 days earlier or something.
Great, thank you, Jen. Michael?
Yeah, let me finish with the strategy then, just an update on a couple of parts of the strategy. So again, I'm assuming knowledge, but there's a lot of people on the call. So anyone who doesn't know, we said with our new committee in April that we would focus for the 3-year term on a few big hitting areas that we would spend a bit of money on, not from levies, but from monies that we've been able to derive from other activity that we do outside of our core roles. And that's enabled us to look at financial sustainability, at safe working, and at the interface. And so some of the pieces of work you will have heard of. The LES dashboard has been really useful for a number of practices. So again, whether Lisa wants to come in a few minutes and talk about any of these projects, but the LES dashboard, we're looking at moving into a new phase of work on it and developing it further. We're also looking at the auto review of results, so that has gone down well for a number of people, and there's obviously some work going on with that. And we ask you to fill in as a practice, to fill in an agreement over this so that we're clear on who does what responsibilities are where, how long the support will be there for. And just say there's another area that we're just exploring in the LMC, and I had a meeting on Friday about this. And it's interesting given what we talked about with pharmacy and with prescribing, but another area we could get some money back from practices on, and this sounded very dramatic in some practices, but it was around PPA claims. So this is around things like, you're prescribing. I know Jen's looked at this before as well, but this is around your prescribing. This is around items you can get paid for administering. And actually, in some places, it's quite clear that there's a combination of stuff going missing and not having a good tracking system for the stop. So a chargeable item is moved or is taken out, or somebody comes into the treatment room, takes it from the fridge, but then the claim isn't made then for it being administered. So there's a lost claim. And coding. So there are disconnects, and we've heard stories on Friday around a group of practices where they saved over £100,000 over a period of years. And this was going back through a 6-year period of being able to claim historically where it hadn't been put in. And of course, if then that means polishing up kind of processes to improve in the future, then that saves money in the future as well. So that sounds like a really big hitting idea that we could industrialize in Nottinghamshire and get out to practices. The areas that have been using it and starting to do it as groups of practices, that we would be groundbreaking to do it at the scale I'd like us to do it, but it has happened on a small level. It's Practice Index who are doing the work, and they have their own, and some people will know this, but they have modules on their website where you as a member can sign up to be part of their finance module, which gets you access to all of their stock management software. And they believe that plus working with pharmacists, So clinical pharmacists from PCNs and working with practice managers, that they can tighten up processes. They can help you to find unclaimed work over the past 6 years. They can save you a lot of money going back and get it reclaimed, and they can save you money going forwards. So the bit we want to do is to kind of just put in the, almost teaching ourselves to do this rather than rely on external people, and then helping you in your practices to then make changes to your processes so that you don't miss this work. So it sounds quite interesting. It sounds like a lot of money that we could get back from practices. And when we're all fighting for extra income, the ironic thing is that there could be times in our practices where actually money's leaking out the back door, as well as us trying to get you more. So we're going to try and do something with that. We've got conversations in the new year with these guys about how we can industrialize this across Notts. And if we get it right, then we could save hundreds of thousands of pounds across Nottinghamshire practices. So we will talk more about that in the new year, but it was really just to give you the heads up that our strategy continues. We're trying to get as many wins for you as we can in practices. So expect to hear more from us over the next few months. Lucy, I don't know whether you or any of the liaison team, Tash, Emma, Stu, want to say anything more about any of the strategy work or anything else that we're doing.
Thanks, Michael. Just a reminder to practices. So Tash is our new colleague who joined us in November, and she's our subject matter expert on all things pathology automation and LES dashboard. But we're very happy to visit practices. So we're at a practice tomorrow to go through the pathology automation and LES dashboard, because we know it's kind of information overload sometimes, but we're really proud of the work that we've done to try and reduce GP workload. So I think 30 practices at the last count had used the pathology automation tool that we've built so far. In January, we're going to be launching another 10 rules. So that will be 20 rules for normal blood results. So just a reminder that bowel cancer, vitamin B12, DEXAs, ACR microalbumin, Usinase, HbA1c, vitamin D, and thyroid function test. But if you'd like us to come out and help you get them set up, please just contact myself and Tash. We're very happy to visit. Similarly, with the LES dashboard, we're going to be moving into phase 2 in January with more searches. So things like the coils and implants and some of the health check work that we can claim back for 6 years. We just want to try and find as many opportunities as possible to recoup costs for you. So that should be launching in January, but do let Tash and myself know if you'd like us to come out and visit. We're very happy to support you in implementing the tools that we've built.
And just to respond, Chaitra put it in the chat about, is there a cost for the PPA stuff? So for the work that we need to do to get this out to you, no, we're looking to use finances that we've access to help through our strategy money that we've got. But certainly that, there might be a cost to you if you want to use the practice index kind of stock management software that they've got, which looks really good. Actually, I had a demo of it on Friday, but we haven't designed this yet. So just, we will talk to you over the next kind of couple of months about the design of this project and about where costs go. But as best as possible, we want to make this as cheap, if you like, to you and your practices and available so that you make that money up in no time through the savings you make. That's the intention. That's all for me, Stu.
Great stuff. Thank you, Michael. Right. Conscious of time, are there any questions from the group at all for Michael or the rest of the liaison team? Silence. Okay, just remember please that we are always here, so please feel free to contact us at liaison@nottslmc.co.uk if you do have any questions that follows this meeting or presentation. We are always there to support you, really. Going into next week then, as our last one of the year for 2024, we're going to be joined by colleagues from the ICB talking about IPC, and also the primary care IT team talking about SMS messaging. So use that as an opportunity to feedback in terms of the recent emails you may have had about SMS messaging. We'll also go into an update about the IRA Fair from Emily Meldrum. And then we'll also be talking or hearing from colleagues about the LIMS and pathology update from NUH. So until then, have a lovely week, stay safe, and we'll see you all next Monday. Thank you very much.